Welcome, everyone. Some of you are new to our echo. It's a psoriasis, psoriatic arthritis echo. Make sure you're on the right Zoom meeting. Some of you know me. I think many of you do actually here on the call. Kristina, Callis, Duffin. I'm dermatologist at the University of Utah, and we have with us Jessica Walsh, who is a dermatologist here at the University of Utah. And I won't introduce every single person on the call, but I will say thank you to Cardin, who is our technical support, and Luke is our CME director, referee, all-around great guy, also dermatologist here at the university. Thank you for your help. And Lisa also there, my admin, to help in the background. And so we have a number of people from Pac-Man here today. We have some folks from industry, some folks from around the world actually signed up, so welcome. I'm going to go ahead and share my screen, and we'll go ahead and get started. For those of you who have not been on an echo before, this is a virtual grand rounds. Our grand rounds here at the University of Utah consists of doing a short didactic, sometimes a case of the week, and then we talk about patients that come in, or in the last 6 months that we took photos of the night before they came in. And so Jesse and I have some virtual cases to present to you, so a case discussion. So I'm going to do the didactic part today with support from Dr. Walsh. And if people have questions, please just let me know. I've put the chat here so that I can see it, but kind of down at the bottom. So I'll try to be able to follow those. If there's a question, you can put it in the chat. We're a small enough group. If you want to interrupt, that's fine too. So what we're going to talk about today is something that I think we frequently see in both dermatology, maybe a little less in rheumatology, but we see it in our gastroenterology population too, which we call TNF inhibitor-induced psoriasiform eruptions. And, sorry, go to the next slide here. These are my disclosures, and one of the things that I want to be really careful about this, like during this part, not to make it feel like I have a conflict of interest and am recommending something. So if you notice something like that, let me know. This is a very interesting topic. It's been an interesting topic for me for a long time. It's actually a pretty common problem in dermatology, and it's of interest to many specialists, and collaboration is really the key for how we manage these patients, because there's not always a right answer or one answer, and it really kind of comes down to trying to find sometimes one drug that will work for multiple conditions. So I'll just start by introducing an example of a case. These are all real cases. A 13-year-old male who had a 3-year history of Crohn's disease. At the age of 10, developed fistula, treated with surgery and infliximab. He stopped the infliximab after things were controlled after several months, and then had a colonoscopy, had active subacute disease, and then was restarted on it. Now, he had a history of psoriasis, minimal amount on his scalp and knees since he was a small child. His father told me since age 5. And initially, this actually improved, all went away on the infliximab. He has a history of known hepatic steatosis, even at age 13. They didn't want to give him methotrexate. And 3 months prior to coming to me, he developed these new palmar-plantar lesions. And so this picture of him, my really kind of bad photography actually is helpful in revealing that not only does he have this kind of odd palmar-plantar psoriasiform eruption that has some, desquamation and redness and fissuring, and there had been some pustules, but he also, you can kind of see his knees back here. He has some plaques there, and even those don't look perfect for psoriasis, but this is what he had. So this is not the first time when he came in that I had seen this, and actually have a series of patients that have this kind of presentation. And you can see here, there's some triangles and some trapezoid figures that kind of illustrate the activity. The flat, longer part is activity and of the disease. So most of them come in with either a story of having Crohn's disease, getting a TNF inhibitor, and then developing psoriasis that they didn't have before, or if they did have it before, such as in his case, that he had a little bit of it, it got a little better, and then it got worse with the reinitiation of the TNF inhibitor, and all the while the Crohn's disease was quiescent, and this may be not quite temporally right. Sometimes this gentleman had prior psoriasis, developed Crohn's disease, started 2 different TNF inhibitors, and each time he went on one, developed worsening of his psoriasis, while his Crohn's was kind of mild and stable through that, tend to respond. So you see kind of different presentations, but they all kind of have the same flavor of having a worsening or onset of psoriasis-like lesions at that time. And it's actually a pretty prevalent thing. Starting back in the 2000s, case series started getting published. The first one in dermatology, we had 123 cases, and there are more in the GI and rheumatology literature as well. So, because again, this is a derm-rheum psoriasis, psoriatic arthritis echo, kind of wanted to illustrate that we see these cases mostly in 3 domains. One are in underlying rheumatoid arthritis patients. Tends to be a bit more common with, in this case, adalimumab. But all TNF inhibitors have been reported to cause this problem across all of these underlying concomitant states. Tends to be a bit more common in females. That's true of RA anyway. And the median onset is about 6 months after starting the drug. The inflammatory disease population, inflammatory bowel disease population, tends to be far more common in patients with Crohn's disease, about 80 to 20 ratio. Tends to be more common to be de novo, up to 70 to 80% of these are de novo psoriasis eruptions, and most commonly is palmar-plantar pustular eruption. More common, somewhat more common in female, a little dependent on the series, and smokers, with a median onset that's all over the onset can be all over the map, but the median's about 12 months. And then we also see this, sorry, I jumped ahead of myself. So this is just one example of a large paper series of over 200 cases kind of illustrating those features. So the larger the case series, the more kind of lands in this realm of what I just presented on the last slide. And then we also see this in people with psoriatic disease, either underlying psoriasis or psoriatic arthritis. What often happens is the morphology will switch from psoriasis at plaque type to other features, like it can be more inverse, it can be more pustular, it can be more guttate. Some series, like 70% of the new ones were guttate. In my experience, a lot of them have pustular features, and sometimes you'll also see kind of a dermatitis-like picture. It doesn't quite look like eczema, it doesn't quite look like psoriasis. You can also see new onset of psoriatic arthritis, which tends to be oligoarthritic and peripheral, and is more of an equal male-female ratio. This is another patient of mine who is in this category of having underlying psoriasis, had classic plaque-type psoriasis, no palmar-plantar involvement at the time that I started him on his TNF inhibitor. He'd had a psoriasis for several years, pretty moderate to severe, 10% BSA, no palmar-plantar involvement. He had a number of things that are, I think, risk factors: smoker, poor oral hygiene, obesity. Started an anti-TNF agent and initially did great. 9 months later, he said he was doing well, and all of a sudden had an abrupt onset of this severe palmar-plantar pustular eruption. This is about as severe as it gets. I mean, he was just literally disabled. So I think his foot was actually taken after he'd been on treatment for a while. The hand was on one of the early days. But he also had new onset of painful and swollen joints of several of his toes. A little bit hard even to see because his feet were so initially affected. It was hard to know what was painful. Was it the skin or the joint? So why does this happen? So there, in the reference, by the way, there's a lot of papers out there, and I can provide the references later if you want. But there are several theories. This one's been rolled out many different times, which is that if you block TNF alpha, it allows for kind of an unchecked, uncontrolled production of type 1 interferons by plasmacytoid dendritic cells, which are thought to be very critical at the very early stage of initiating disease. And so it's been called a paradoxical response, therefore inducing psoriasiform lesions. And paradoxical, I think, has been used kind of grossly as, well, it's paradoxical that I gave somebody a drug that's approved for this condition and then they got psoriasis, right? That's paradoxical. So this is one mechanism that's been brought up. More in the Crohn's disease population, there have been a couple of studies showing that some patients are homozygous for polymorphisms in the IL-23 receptor gene compared to disease-matched controls. And to further support that, beyond the genetic studies, there have been some functional studies where the researchers have drawn serum and done skin biopsies and shown that there are higher IL-23 and IL-17 levels of those cytokines in the serum and the skin. But then I ask the question, is that the chicken or the egg? Okay, like if you have psoriasis, those might be higher anyway, right? So it suggests a potential role for IL-23 therapy, but I don't know that that's really a valid statement. Also, what is observed, again, with observational studies is that patients who have this may just already be at risk, right? We know that psoriasis is a complex, multigenic disease, as is probably many other of our diseases, including IBD. And we know that if you have IBD, you have a higher prevalence of having psoriasis, about 9.6%, upwards of some studies even higher than that, having psoriasis if you have underlying Crohn's, and 5.6% of patients with ulcerative colitis, whereas the general population is in the 2 to 3%. And then another thought is permissive infection, because the other common outcome or adverse event of TNF inhibitors after you look at upper respiratory infections is skin infections. And so, for example, there's a condition called keratoderma blenneragicum, which histologically looks like pustular psoriasis and clinically looks like it, which is thought to be induced by chlamydia. And certainly other diseases can have, obviously infection. There can be pustules, bacterial infection. So those things could also be at play here too. So few more slides, just kind of talking on management considerations. So when I have a patient like this come into clinic, the first thing that I am doing is taking down the phone number of their other providers, their gastroenterologists, if they have Crohn's, their rheumatologists, if they have joint disease, to talk to them before I do anything. One of the things that patients with Crohn's and arthritis and psoriasis, they're so worried, they're so anxious about losing control of their disease, that if you have a patient who walks in the door as IBD and they're totally controlled on their drug, they're really nervous about changing because they don't want to lose control of their disease. And so we have to approach this carefully with all of our consultants on the same page, because they don't want to see that either. And the next question, is the underlying disease controlled? Because obviously it's a different conversation. If the underlying disease is not controlled, obviously we need to do something different. And then, and some of the studies have shown that patients with IBD actually present with controlled symptoms, but uncontrolled cutaneous disease. And that's been very common in my experience. And then how severe is the psoriasis? So could you treat through it, or do you need to add systemics and or change things? So this is from this giant paper published in 2019 that was the lead author on this was Joe Marola, who is a dermatologist and a rheumatologist and a leader in Pac-Man. And he and Lourdes Shada Perez, also an author on that, put this algorithm together. And I find this to be a little bit busy, so I broke it down on the next couple of slides. So we're going to come back to this, but you can kind of see that they broke it down: mild skin disease versus moderate to severe, controlled and uncontrolled underlying disease, and how you can approach it. So I think this is an interesting model. There are some things that need to be kind of refined and updated on it, but I think it's a good conceptual model. So from a derm standpoint, the first thing I think of is, well, if it's relatively mild, can you just treat it with topicals and treat through? In other words, if their disease is controlled, their underlying inflammatory bowel or RA is controlled, maybe you can just get through this with some topicals, or maybe even adding other things like UV, and just continue their TNF inhibitor. And there's a couple of studies that support pretty good results just doing that. You know, a quarter to upwards of a half will totally clear doing that. Partial response in a kind of similar ratios, 25 to 57%. So it's certainly a good approach if you feel it can be treated with topicals. Obviously, my guy with pustular disease couldn't be that. And then when you're in a moderate to severe skin disease realm, again, with these considerations, you then have to divide into the domains of the underlying concomitant disease. So you're going to have a different set of things that are going to be in that 2 birds or 3 birds with 1 stone concept. So for RA, considering a different TNF, stopping a TNF for a time, switching to something else, methotrexate, tofacitinib, which has some efficacy data in psoriasis but is off-label, approved for RA, abatacept, same story. Very limited data in psoriasis, done mostly in psoriatic arthritis, not very effective for psoriasis, abatacept. Inflammatory bowel disease has different drugs. Again, TNF inhibitors, ustekinumab, tofacitinib on this list, again, in the same off-label qualification for psoriasis. And then for psoriasis, you have your usual suspects of, again, another TNF, IL-12, 23, or IL-23 inhibition, IL-17 inhibition if there's no inflammatory bowel disease, tofacitinib, apremilast, methotrexate, cyclosporin, adding UV, all those things are on the list. So plenty of choices, just have to concoct the right plan. And then the last of my data slides is this. So before tofacitinib came along, when I had patients like my young man who at the time was 13, this was a few years ago, before ustekinumab got approved for Crohn's and approved for children for psoriasis, we were using it because we had good success using it in some of the adults. And there are actually pretty good studies out there, not randomized trials, but good observational studies and case reports suggesting, one, that first of all, moderate to severe Crohn's can be treated with ustekinumab after failure of a TNF agent. And although it's not studied first-line biologic for Crohn's disease at the time I made the slide, at least, there are many cases reported in the literature. And anecdotally, all of the at least 6 patients that had walked in the door with this, I had opportunity to try ustekinumab and another patient with tofacitinib. So my experience has been in line with what the literature says. I don't want you to think I'm making a recommendation, but I have seen success with this as an option. So I'm going to stop for a second and ask, I'll stop sharing my screen and just ask some of the rheumatologists on the call if they, how they have viewed this problem. How often do they see this eruption in their patients with underlying psoriatic arthritis and rheumatoid arthritis? And how do you manage it if you have tricks up your sleeve? I'd like to hear about them. And then how about seeing if there's some other dermatologists on there approaching patients with IBD, with skin disease, and then if they have arthropathy, how do the 3 groups kind of work together to do this? So maybe, Jesse, I'll put you on the spot first and ask you about your experience with seeing this in patients with psoriatic arthritis and RA.
Yeah, so I think it's can be difficult to recognize, particularly in the psoriatic arthritis patients, in terms of, is this a TNF induced or is this just their disease? But you know, the palmar plantar pustular psoriasis, I think I think I see most of them with you, but I not exactly sure I would know a percentage there, but I think there's a fair amount of them. With RA, you know, the literature suggests a little bit more. That's probably 2 to 3% of TNF induced. 2 to 3% of RA patients on a TNF inhibitor will get it over time. And then in terms of how to treat it, I think with, and we'll talk a little bit more about that, but it differs quite a bit according to the disease state. With our RA patients, one of the questions I think I'd like to discuss more as we go along is withdrawal of a TNF inhibitor good enough? Will the palmar plantar pustular psoriasis go away, or do we need to actively treat it with an agent that covers both the underlying disease, so the rheumatoid or the psoriatic arthritis or the IBD, plus treatment for the psoriasis? I don't know if other people have much experience or thoughts on that.
All right. Yeah, I think these are tough. You know, these are tough. And I think you're right that one of the first things you have to do here is, as a rheumatologist and as a dermatologist, you have to say, is what I'm looking at psoriasis or psoriasiform eruption from the TNF, or is it something else? And that's, again, where, you know, Jesse and I have been quick to shoot patients over to each other to say, please weigh in on this, because we have to do that. And sometimes it's not psoriasis, right? And we're going to talk about that in a second. Any other quick comments before we go on? I think we've got just some more cases to kind of go through to kind of illustrate this and kind of talk, and then we'll jump into some other cases that we have that both of us have just had on our minds in the last few weeks. And so we just thought we'd bring them. And then if anybody else has a comment or a case they want to bring up. So Luke, did you want to say something?
I have a question. So if you do withdraw the TNF inhibitor and we think it was responsible, how long does it take for their skin disease to clear?
It's a good question. I have seen it take a year. I have seen it take a few weeks or less, and it's super hard to predict. I've wondered sometimes if it just sort of destabilizes their disease. The gentleman that has the pustular stuff on his hands, we're still dealing with this, and it's like it reset his phenotype. You know, it's like he's got pustular disease. That is a reset of a phenotype, and I don't know what to make of that. I don't know. I was reviewing my own slides and thinking about chlamydia and, you know, like, do I need to do more of an infectious workup with him? And, you know, there's a lot of different things that are going on with him. So Mr. made me kind of take a step back, make sure there's not something I'm missing.
How much does the risk of this particular entity influence your decision about which biologic to use?
So, great question. It totally leads into one of our cases. So perfect.
Intentional.
So thank you. Absolutely. For patients with palmar plantar pustular disease, absolutely, this is an issue. So somebody has palmar plantar pustular disease as their primary phenotype. I don't like to start with a TNF inhibitor, regardless of their underlying state. Okay, so if they have underlying but Crohn's disease, I might not have a choice. Might have to be where we go. Might try to push the GI to go to an IL-23 inhibitor. Again, they don't usually think of it as on first line. For somebody with psoriatic arthritis, we have IL-17 inhibition, so we can start there. So I try to push Jesse, like, please don't, let's not go to the TNF, even though that is considered first line in the guidelines for psoriatic arthritis. So I think about it if that's their phenotype. So, but I think from a rheumatology standpoint, because it's not that common initially, I don't know that it changes your approach. Is that true?
I would agree. I don't generally select medications or not select a TNF inhibitor because I'm worried about palmar-plantar pustular disease. But again, Kristina is teaching me with palmar-plantar disease to try to at least consider it, get around a TNF.
Yeah, and there's just other things you have to be considering along the way, like secondary infection. Sometimes people flare and they get steroids, and that can induce weird phenotype switches. So all those things have to be considered. So just going back to the slides, and please interrupt me if you need. So
I have a question, Kristina, in sort of a related topic, but with the IL-17 inhibitors, have you been seeing IL-17 induced psoriasis? And in the few cases that I've seen, it's always been a little unclear. They've been more of the inverse psoriasis versus like a mucocutaneous fungal infection. That's always been in the differential, but I haven't seen any purported palmar-plantar sort of induced psoriasis in those cases. I'm curious if you have.
So I would say yes, exactly. I've seen some patients have unusual like skin rashes. I've had a couple of people in the last couple of weeks, in fact, that have had kind of odd urticarial and drug rash-like things happen, which are, I think, really uncommon with the biologics in general. Just don't see that very much. So I think things come in twos and threes sometimes in weird pockets. But I've not seen a lot of that, but I have absolutely seen it with every drug. So I've seen people with IL-17 and IL-23 inhibition get palmar-plantar pustular psoriasis, or at least see it worsen. So usually it's around people already have palmar-plantar disease and then they just don't get better or they worsen. But it's not common at all. It's really pretty rare. But I have seen it. I just have seen it a lot less than I've seen it with TNF. And, I think when we were talking, that one slide with the bubbles and says, adalimumab may be more common in RA and infliximab may be more common with IBD. It's totally related to like how the history of how we use those drugs in this realm, right? Because we didn't have a lot of use of adalimumab for Crohn's disease initially, right? Everybody's using infliximab. So it's maybe the numbers aren't quite right.
So Kristina, hi. Sorry, now I'm driving. I'm sorry, I shouldn't be doing that. But I'm kind of curious. So what would you do in this case if you see the palmar-plantar side effects with the anti-IL-17 and 23 inhibition? So that's kind of a difficult thing. I think I have a patient that is doing just this right now, and I don't know what to do. I'm thinking about taking out everything and see what happens.
Yeah. Everyone out of the pool is sometimes a good strategy, right?
Yeah.
Right. I like that strategy. It works pretty well sometimes. Thanks, Claudia, for joining us. So this is quite a global meeting. So thank you for joining us. So what I generally would do is start asking a bunch of questions about that patient. So like if they have underlying psoriatic arthritis or RA, how is their disease control? I feel like stopping the drug and then sometimes adding cyclosporin just to cool them off is usually my first strategy. So I'll say, and I had this happen. This is a pretty good example. I have a woman who had been on adalimumab for rheumatoid arthritis, developed, had something happen, needed to go in the hospital, came out after being off it for a couple months, restarted it, and then developed this palmar-plantar eruption that was pustular. And so what we did with her is stop her cycles. We stopped her adalimumab. We added cyclosporin, and it cleared. And after a couple of like stop trying to get her to off the cyclosporin, she was able to come off it all the way, but then she needed to go back onto something for her RA. This case happened quite a number of years ago, so we didn't have a lot of options. Like we didn't have abtacid at that time, so we didn't have other things to try. And so I think they're really tricky, but that's generally how I will calm them down first. If they have underlying RA, I think it's harder to find a drug to treat both conditions with. If they have underlying IBD, I've used a lot of ustekinumab. So does that answer your question?
Yeah, I guess so. That's what we have to do. You know, this patient I just saw yesterday, just to be kind of more complicated, she also has like a nuclear antibody that became positive in a nuclear pattern. So that's very strange. I don't know if she's like changing her clinical picture to like something more with Raynaud's disease as well, and this nuclear antibody resembles something like scleroderma. So it's like a second opinion patient. So she has been very manipulated with all 3 anti-TNFs, then secukinumab, and that's what's going on now. Hard case.
Jesse and I were talking about a patient last night, and we were talking through the scope of this talk today, who had been through 3 different TNF inhibitors, and on his 3rd one would get it. It was infliximab was the 3rd one, and get an infusion, and he said his skin would get a little better, but then he had these arthralgias and all this stuff that was unexplained. And after it's happened a couple of times, we're like, gosh, does he have drug-induced lupus? Because that's certainly been seen. And sure enough, he had a positive ANA, and we ended up stopping him and put him on an IL-23 inhibitor, and he's done very well on that. So, so you obviously have to think that way. You have to wonder if, because we know that's a risk factor for all anti-TNF agents. So, you know, I think it's a important thought to kind of wonder about drug-induced lupus. But you know that some percentage of people on TNF inhibitors will have a positive ANA, and it's not related, right? It's unrelated. So
thank you.